Hi, it's Betty with Eye Specialty Group. We're going to continue our conversation this afternoon with Dr. Andrew Krause, one of our retina specialists here in Eye Specialty Group. We started off by talking about the signs and symptoms of macular degeneration. Today we're going to talk about possible treatment plans. Dr. Krause, we realize that there are two types now, wet and dry. What would a treatment be or a treatment plan be if I were a patient and come in presenting symptoms to you for wet?
Okay. So wet macular degeneration occurring in about 10% of the population has a treatment very effective. These molecules are called anti-VEGF, anti-vascular endothelial growth factor. They inhibit the growth factor that stimulates abnormal blood vessel growth. Three types. They're largely similar in effect, and very often insurance will determine what can be used and what can't be used.
Got it, yeah.
Typically going to start with one and move to another if we're not happy with the result or the outcome. So these are injections that are placed directly into the eye. Sounds scary, always. I would be scared. But patients really tolerate it extremely well. We make their eye numb with a topical cane drop, and we use an iodine solution to disinfect the eye. Patients really do not typically feel the actual needle entrance into the eye. They will commonly feel their eye being held open with a speculum so the skin is stretched, so we have exposure or access to the eye, to the globe where we inject. And afterwards the eye is washed out and patients go about their business. The treatment risks are most common is a hemorrhage at the side of the injection site, which patients don't actually feel. Other people can see it.
Does it look like a bloodshot eye?
No, it looks like a usually focal area of a hemorrhage.
Okay.
Many patients might be familiar with having subconjunctival hemorrhages where they wake up spontaneously, they look in the mirror and there's a capillary is broken. It's very dramatic red, but these things will go away commonly. The real concern is an infection or endophthalmitis, infection on the inside of the eye, which we do a pretty good job preventing, and the incidence of that's really 1 in 3 to 5,000 patients. And in those patients, they often have to undergo antibiotic treatment or even surgical treatment for removal of the infectious agent.
Right.
The eye is not sterilized, it's disinfected. There's no way to truly sterilize like you would sterilize a piece of surgical equipment.
Right.
So the treatments, the medications, all three of these currently have a duration of about 30 days inside the eye. We treat based on the findings of our what we call an OCT. We take an image of the back of the eye. It indicates whether there's fluid in the retina or under the retina, and we follow that sequentially. Patient receives the first injection at the time of being diagnosed. Then they come back typically for 2 more injections, so you'll have 3 injections to start with. Second and third time, I don't typically dilate the patient. We just get the image finding, and I see that patient again in 3 months. If there's no fluid at the time, which is a successful treatment, if we've eliminated the fluid from in or under the retina, we will usually treat, and then what we do is we call treat and extend. We go from a 4-week interval to a 6-week. If we're successful at 6 weeks in preventing fluid from returning, we go to 8, 10, and 12. And very often patients will have a course of treatment and not need treatment again. It's difficult to predict who that patient will be. There's no markers that we have that will say if you've had 3 injections, you're going to need 6. If it looks a certain way, you'll need this number. It's
doesn't matter male or female at all. No factor when it comes to that.
There's no real factors that tell you once you've become a patient with a wet, how you're going, what the outcomes are. They're just statistical models that you will fit into in terms of number of letters that people can improve by. 40% will have improvement, 95% of patients will have stability. At the end of a course of 2 years, if you look at the studies, still a significant number of patients will have fluid in the retina or under the retina, but those patients can also have significant visual improvement. It's not always correlated, but we like to see an absence of fluid present because it allows us to feel more comfortable in spreading out the time between treatments.
If the definite injections were not to work, what would be plan B?
Well, You have 3 types of injections. Typically, there's going to be some benefit with
Okay.
the 3. Suppose you've run through all 3 of them, you've given adequate trial. I think in the Retina Society at about 3 to 5 injections. If you find that one's not getting the response you want, most doctors will go to another one in
injection.
the same class of drug, meaning anti-VEGF. It's not been shown that the final outcome in 2 years is that much different, but we will still do that. It's very unusual to have a non-responsive eye. It can be the case. Doctors will go to using a steroid just to move the needle a little bit.
Okay.
There's also older treatments that we use, photodynamic therapy, which was a treatment really early 2000s that was utilized. That's a way of injecting a medicine into a vessel in the arm. It accumulates in the retina. A light is shined into the eye of a certain wavelength, and that can decrease or eliminate these blood vessels. However, in those treatments, that treatment was approved by the FDA as a mechanism of decreasing the loss of vision, not increasing vision from the starting point. So it's completely different than these medications that we use now, which is why we rarely ever veer away from these. There's nothing better in the sense they are miraculous. They're utilized for all vascular retinal problems, and on the horizon are molecules of a similar type which will have a longer duration. So the real issue for the patient is, how often do I have to come back?
Right.
How many, in other words, how many injections will I have to have? How long will I have to have treatment? Will I ever be able to stop?
Right.
We have medicines now that will go, the goal is to have a medicine that's in the eye for 3 months versus 1 month, and these are on the horizon.
Oh, good.
Really in phase 3 trials. So that's to be expected, and of course there are other methods of delivering these medications. Some are surgical, that'll deliver a medicine over time for 6 months. A depot that you'll fill up and it'll continuous delivery of a medication, so patients need less and less returns, because it's a burden on patients, the frequency, etc.
Are there any side effects?
Side effects of the medicine?
Yeah.
Very uncommon.
Okay.
Historically, they felt that there was some associated cardiovascular risk of stroke, heart, other things. Over time, we've done so many injections over time. Those risks are not in the same population, taking a population typically 60 years or older, hypertension, diabetes, heart disease, cardiovascular disease, other diseases. They're common if you match those populations with macular degeneration without these incidents of heart disease, cardiovascular, stroke, etc. is largely the same. So it's kind of been eliminated as a risk factor over time.
Okay. So
Still leery of that because historically the early classical studies showed some increased incidence of stroke, but over time I think that's been it's not something you dismiss, but statistically it hasn't been shown after you've seen so many injections, so many patients.
So other than if I were a patient visiting you and I've recently been diagnosed with macular degeneration, other than you explaining the treatment plan to me and how long I might be on it and the side effects, is there anything else a patient should know when they're in the room with you?
Basically speaking, you're going to want to know how to prevent this in the other eye. And most patients will have bilateral disease, but different in extent. So if the fellow eye has dry macular degeneration, there's a way of assessing the risk of the dry becoming the wet, the percentage of those patients that will convert, we call it, to the wet type over a 5-year period. The way to lower the risk is using the AREDS 2 formula vitamins, nothing magical, but 6 specific components that lower the risk of the dry becoming the wet by 25%. So we do recommend that, and the fellow eye has intermediate findings, not early findings. Early findings have shown no benefit by taking the AREDS formula. So it's an intermediate finding, and that's based on the findings in the eye, drusen pigmentary changes, these various characteristics of macular degeneration. There's nothing specific at this time. There is no treatment to slow down aging, although that is truly on the horizon, because the incentive is you have far more people with the dry type that are worried about loss of vision. Wearing away of this tissue is the issue in dry type, and all kinds of molecules are now being studied to see whether you can slow down the wearing away of this one layer of the retina. Nothing specific or close directly to FDA approval, but everyone is looking at it.
I feel like 2020 or 2021 might be the year that we have some new
Everybody would love that.
FDA. Yeah. There are several times you mentioned that there's a lot on the horizon, so it sounds like
Yeah,
we
there
just need
is.
to get that FDA approval.
There is, but the data yet for the dry type, I'm not so sure how far out that is. For the wet new molecule, that is in phase 3, and that's, I think, imminent.
Do you participate in any research studies?
We're about to be participating in some, yeah.
Great. Thank you, Dr.
You're
Krause.
welcome.
So, again, if you or a loved one suffer from macular degeneration and you have any questions, please feel free to call our office at 901-685-2200 to schedule an appointment with one of our retina specialists. This is Betty, along with Dr. Krause. Thanks so much.